Welcome to the deep dive. You handed us quite a stack of materials today, and I have to say, looking at all of this side by side reveals just a totally wild medical paradox.
Oh, it really does. It's fascinating.
Right. Because we're looking at a potential cure for an agonizing chronic autoimmune condition, but it isn't currently being pioneered in some sterile hospital research wing.
No, not at all.
This being pitched right next to Botox and dermal fillers in, like, regenerative aesthetic clinics.
Exactly. Which is a huge shift.
It is. So our mission today is to synthesize this stack of sources you gave us to explore a pretty bold question. And that is, can intimate exosomes actually treat vulvar lichen sclerosus?
Yeah, and to really unpack that, we're looking at massive, highly regulated documents. Like we've got the Euroguiderm guidelines and the NHS standard.
Right, the official heavy hitters.
Exactly. And we're contrasting them directly against, well, promotional materials from private med spas.
Which is quite the leap.
It's a massive leap. Plus, there's a stern patient safety warning out of the UK in here, and a very recent, highly specific clinical case series.
So we've got a lot of ground to cover.
We do. And the tension between the slow, cautious world of established medicine and the absolute wild west of regenerative aesthetics, I mean, it is palpable in these pages.
Oh, you can feel it immediately. But before we get to the exosomes and the wild west of it all, we really need to set the baseline.
Yeah, we have to talk about the reality of lichen sclerosus, or LS.
Right, because vulvar LS is, well, it's severe. It's a chronic, long-term inflammatory skin disorder.
Yeah.
And officially, there is no known cure.
None. And according to the University of Bristol guide in your stack, the pathology involves a localized autoimmune attack.
Meaning the body is essentially attacking itself.
Precisely. The body ramps up these inflammatory cells, specifically T cells, and they congregate right at the dermal-epidermal junction.
So right where the skin layers meet.
Yeah. And the mechanism of that attack is what causes such devastation. Those T cells release this absolute storm of cytokines.
Like an inflammatory storm.
Exactly. Which essentially forces the normal tissue remodeling process to just go completely haywire.
Wow.
We see a complete homogenization of collagen in the upper dermis and a loss of the ridges.
And those ridges, they normally anchor the skin layers together, right?
Right. So when you lose them, the result is severe epidermal atrophy. The skin just thins out drastically.
Which explains the brutal symptoms. I mean, the sources describe relentless, intense itching, a constant burning sensation, and dyspareunia.
Painful intercourse, yeah.
Right. The tissue becomes so compromised, so fragile, that it's prone to active fissuring. It literally tears.
It does. And if it's left uncontrolled, the anatomical changes are irreversible.
That's the scary part.
It is. The sources outline how the labia can completely fuse together, essentially burying the clitoris and significantly narrowing the vaginal opening.
Just an immense physical and psychological toll.
Absolutely. And beyond that, uncontrolled LS carries an increased risk of developing vulvar squamous cell carcinoma.
Vulvar cancer.
Yes. Which is why the current standard of care is so aggressive.
Okay, let's unpack this standard of care. Because looking at the Euroguiderm guidelines and the protocols from Addenbrooke's Hospital, the gold standard treatment relies on ultra-potent topical corticosteroids.
Mostly clobetasol propionate, the 0.05% ointment.
Right, and these steroids, they are not messing around.
No. Glucocorticoids like clobetasol are incredibly powerful. When you apply them, they penetrate the cell membrane, bind to receptors in the cytoplasm, and literally travel into the cell nucleus.
Wait, all the way into the nucleus?
All the way in. To actively alter gene expression. They downregulate the production of inflammatory proteins.
Wow.
And they inhibit the migration of those destructive T cells into the tissue. They essentially forcibly shut down the local immune response.
So it's basically like a pharmaceutical fire extinguisher.
That's a really good way to put it.
You have this chronic inflammation destroying the tissue, the fire, and the steroid comes in and puts out the fire so the house doesn't burn down completely. But the limitation of a fire extinguisher is that, well, it doesn't rebuild the house, it doesn't fix the tissue that was already damaged.
No, it doesn't. The steroids halt the progression, and they ease symptoms beautifully for patients who comply with the regimen.
Which is huge for their quality of life.
Absolutely. But the paradox here is that topical corticosteroids actively inhibit fibroblast proliferation and collagen synthesis.
Wait, really? So they stop the body from making collagen?
Yes. So not only do they fail to fix the tissue that was already thinned or scarred by the disease, long-term use can actually exacerbate epidermal thinning.
Oh, wow. So you're treating thin skin with something that makes it thinner.
In a way, yes. Dermatologists and gynecologists are forced into this very delicate balancing act. They're trying to suppress the disease without chemically inducing further atrophy.
That sounds like a nightmare to manage. So we have patients who have had the immune fire put out, but they are left living in the burned-out house.
Exactly.
The lost elasticity, the scarring, the narrowing, all that structural deficit remains. And that exact void is where the marketing for regenerative medicine makes its entrance.
Specifically exosomes.
Right. Enter the exosomes. Because the concept of regenerative aesthetics shifts the focus entirely, doesn't it?
It really does. Based on the sources, exosomes are microscopic extracellular vesicles. They are these tiny nanoparticles naturally released by stem cells.
Okay, wait, so they aren't stem cells themselves?
No, and that's an important distinction. In the early days of regenerative medicine, the focus was on injecting stem cells directly.
Right, that was the big buzzword.
But stem cells carry real risks, including the potential for unregulated growth or even teratoma formation like tumors.
Likes. Okay.
But researchers realized that stem cells don't actually do the healing themselves. They secrete exosomes to orchestrate the healing.
Ah, I see. Because exosomes aren't cells.
Right.
They don't have a nucleus, they don't replicate, they're basically just cellular messengers.
Exactly. They are tiny lipid envelopes packed with mRNA, proteins, peptides, and growth factors.
And the way they deliver this stuff is wild.
It is fascinating. Because their outer layer is a lipid bilayer, much like our own human cells, they can travel through the interstitial fluid, dock onto a damaged target cell, and literally fuse with its membrane.
They just merge right in.
Yep. And then they empty their payload of mRNA and growth factors directly into the target cell's cytoplasm.
So they essentially hack the damaged cell.
That's a great word for it. They hack it, overriding its current state and instructing it to begin localized repair.
So going back to our analogy,
Right.
if steroids are the fire extinguisher, exosomes are being marketed as the construction foreman.
Right.
They show up to the site, hand out blueprints to the local workers, and tell your body exactly how to rebuild the house.
That's exactly how the marketing positions it. And in the context of the vulvovaginal area, med spas like Rejuve Med Spa and Dr. Sharon Lay's clinic mentioned in the stack are pushing this heavily for women's intimate health.
Yeah, the brochures are very persuasive.
They claim exosomes stimulate those dormant fibroblasts to ramp up collagen and elastin synthesis. They also highlight neovascularization.
Which is the creation of new blood vessels, right?
Yes, and a rapid decrease in oxidative stress.
So you can see why the appeal for an LS patient is undeniable.
Oh, absolutely.
Moving away from a lifelong reliance on ultra-potent steroids toward a treatment that promises to actively revitalize the tissue, to restore structural integrity. That is a massive paradigm shift.
It moves the goalpost entirely, from symptom management to actual disease reversal.
But of course, marketing brochures are designed to sell you something. The real test is what happens when this biological hacking is applied to actual patients in a clinical setting.
And that brings us to the case series.
Right. Here's where it gets really interesting. Your sources include a very recent clinical case series published by OAS Publishers, authored by Dr. Shuri Kaplan.
It involved 10 patients?
Yep, 9 women and 1 man, which is a good reminder that LS causes severe penile atrophy and strictures in men as well. It's not just a women's disease.
Very true.
And these patients ranged in age from 39 all the way up to 88 years old. But reading through Dr. Kaplan's protocol, they didn't just slap some exosome serum on and send the patients home?
No. They used a highly aggressive multimodal treatment protocol.
Very aggressive.
The multimodal approach is designed to essentially force the body into a receptive state. The patients received up to 3 treatment sessions, spaced 14 days apart.
Okay.
First, they utilized 360-degree monopolar radiofrequency.
So heat?
Deep heat. Monopolar RF delivers bulk, controlled thermal energy deep into the dermal layers. This heat actually denatures existing damaged collagen, causing it to contract.
Wait, so it shrinks the bad collagen?
Exactly, while simultaneously triggering a heat shock response that forces fibroblasts to generate new, healthy collagen.
But they didn't stop there.
No, they didn't. Second, they used fractional RF microneedling.
Okay, so needles now.
Yes. Instead of bulk heating, this uses a matrix of tiny needles to puncture the tissue, delivering thermal energy directly into the lower layers of the skin.
So they are intentionally traumatizing the tissue.
They are. It triggers a natural wound healing cascade hemostasis, inflammation, proliferation, and remodeling. It is a calculated, controlled injury.
Wow.
And only after this deep thermal heating and mechanical puncturing did they introduce the biologic agents topically.
The exosomes.
Primarily exosomes, yeah. Sometimes combined with platelet-rich plasma or PRP. The theory here is that the energy-based therapies prepare the tissue and create open channels.
Like literally punching holes for the serum to go into.
Right. And then the exosomes provide the concentrated biological signaling to optimize the repair phase that the body is already starting because of the trauma.
Well, the results reported in this study are staggering.
Yeah.
I mean, 100% of the patients reported a drop in distress related to the inability to orgasm.
100%.
88% had relief from that agonizing itching and burning. 75% had their vaginal dryness resolved. But the stat that really blew me away, 80% of the patients who entered the study dependent on topical steroids were able to completely discontinue their use.
It's an incredible outcome. And the clinical observations of the tissue transformation really support those statistics.
Like the 88-year-old patient.
Yes. She presented with marked atrophy, severe erythema, and active fissuring.
Just actively tearing skin.
Right. But following just a single session of this combined RF and exosome protocol, the clinical notes indicate the tissue appeared smoother, the fissures had resolved, and hydration visibly improved.
After one session. That's wild.
And the male patient experienced a complete resolution of his penile atrophy and active tears, which allowed him to cease corticosteroid therapy entirely at his 4-month follow-up.
Okay, but wait a second. Looking at this rationally, I have to push back on the methodology here.
I was wondering when you would.
I mean, this sounds amazing, but they threw the absolute kitchen sink at these patients. Monopolar RF for deep bulk heating, fractional RF to literally stab the tissue with hot needles to create thousands of micro-injuries. And then they apply exosomes.
It's a lot all at once.
Right. With a study size of only 10 patients, determining the variable of efficacy seems impossible. How on earth do we know it was the exosomes doing the heavy lifting?
You're asking the exact right question.
Because couldn't the body's own dramatic healing response to the thermal and mechanical trauma of the lasers and microneedling be responsible for the regeneration? Independent of the exosomes entirely.
Yes, that is the most persistent hurdle in modern regenerative medicine right now.
Okay, so it's not just me.
Not at all. When therapies are stacked in a multimodal protocol like this, separating the synergistic effect from the individual variables requires a massive, placebo-controlled, randomized trial.
Which this was not.
Definitely not. Did the fractional microneedling do 90% of the heavy lifting, merely utilizing the exosomes as a minor catalyst? We don't know. The researchers themselves acknowledge this limitation.
So scientifically, the specific contribution of the exosome payload remains completely obscured by the aggressive application of the energy devices.
Exactly. We know the combination works, but we can't isolate the hero.
Which brings us to the inevitable reality check of this whole deep dive.
The clinical guidelines.
Right. If a treatment can potentially reverse scarring, resolve fissures in an 88-year-old, and get 80% of patients off ultrapotent steroids, the obvious question is why it isn't the global standard of care.
And if you look back at the official Euroguiderm guidelines and the NHS standards we started with,
exosomes are completely absent.
not even on the map. The distance between a promising 10-person observational case series and actual inclusion in international clinical guidelines is vast.
Decades, sometimes.
Exactly. Now, the official guidelines do explore adjunctive therapies. They discuss the use of fractional CO2 lasers and platelet-rich plasma.
But not exosomes.
No. And even with lasers and PRP, the consensus of the medical establishment is that the data remains highly mixed. There is a profound lack of longitudinal data regarding long-term safety and sustained efficacy.
And these guidelines are conservative by nature.
They have to be. Their primary mandate is do no harm. They require robust, undeniable proof that repeatedly traumatizing autoimmune compromised tissue with heat and needles won't inadvertently trigger a massive inflammatory rebound years down the line.
Oh, wow. I didn't even think of that. Like,
Yeah.
you poke the bear now and it seems fine, but 5 years from now, the inflammation comes back tenfold.
Exactly. And beyond the lack of long-term data, your sources highlight a darker side to the regenerative aesthetic industry.
Yes, the UK safety warning.
Right. The patient safety warning from SafeFace and Enhanced Insurance in the UK exposes a massive regulatory loophole.
Okay, break this down for us.
So exosomes can be synthesized from plant, animal, or human sources, but under UK law, human-derived exosomes are strictly classified under advanced therapy medicinal products. Meaning they are illegal to administer as an injectable without highly specific licenses.
Wait, illegal?
Yes. The regulations surrounding human-derived tissue products are incredibly stringent and for a very good reason. They require exhaustive screening for communicable diseases, rigorous viral inactivation processes, and absolute batch consistency.
To prevent, like, severe immunological reactions or infections?
Exactly. You're putting human material into another human. But to sidestep these massive regulatory and financial hurdles, aesthetic clinics utilize a classification loophole.
Loophole.
Yeah. They label human-derived exosome serums as cosmetic topicals.
Meaning they just rub it on the skin, they don't inject it.
Officially, yes. And this perfectly explains the microneedling protocol in the aesthetic setting.
Oh my gosh, of course. Because human-derived exosomes are restricted injectables, clinics use microneedling to literally drill thousands of microscopic backdoors into the skin.
Precisely.
And then they simply spread the exosome serum over the area, allowing the nanoparticles to seep into those backdoors. They achieve deep tissue penetration similar to a syringe injection, but legally.
Legally, they only apply to cosmetic topical.
That is wild. By exploiting that topical classification, they completely bypass the legal definition of an injectable drug.
And it creates an alarming gray area in patient safety. Patients are receiving products that may lack standardized purity, stability, or rigorous clinical testing.
And these products are being introduced deep into highly compromised, diseased tissue.
Right. Furthermore, if a clinic uses plant-derived exosomes to stay strictly within legal boundaries, well, there is ongoing debate about whether plant exosomes even possess the correct surface receptors to effectively bind to and hack human target cells.
So you might be paying thousands of dollars for plant juice that your cells can't even read.
Basically, yes.
So placing yourself in the position of a patient navigating this landscape reveals just a profound dilemma.
It's an agonizing choice.
You have a devastating chronic medical condition that destroys sexual function, causes immense daily pain, and carries a legitimate risk of cancer. The conventional medical system offers a powerful steroid that suppresses the disease, but it slowly thins your skin and cannot repair the structural damage already done.
It's symptom management.
Right. Conversely, the rapidly expanding aesthetic industry offers a tantalizing chance to actually regenerate your body and reverse the damage. But are you comfortable taking it out of your dermatologist's office and treating it at a med spa with a product that might be exploiting legal loopholes depending on what country you're standing in?
Exactly. You are purchasing a treatment that lacks large-scale clinical proof, administered in a med spa setting. It's a huge risk.
So, synthesizing all these sources you provided, the landscape of treating vulvar lichen sclerosus is sitting right on a fault line.
There really is.
We have the established, heavily regulated world of symptom management standing in stark contrast to the unregulated, highly promising frontier of tissue regeneration. The early data, like Dr. Kaplan's case series, suggests that combining thermal trauma with the biological signaling of exosomes could genuinely revolutionize how we approach chronic inflammatory damage.
But the hurdle is time and data. And if we connect this to the bigger picture, as regenerative aesthetics continue to evolve faster than clinical trials can keep pace, we are watching the total blurring of the line between cosmetic enhancement and vital medical care.
It's all bleeding together.
Yeah. I mean, if a private med spa can routinely demonstrate the reversal of tissue damage that major hospital systems can only chemically suppress, how long until our traditional medical frameworks are forced to rewrite the parameters of what constitutes an approved medicine?
That is a fascinating point. It really leaves you wondering about the ultimate trajectory of this technology. Like, if we can successfully code an exosome to instruct localized tissue to stop attacking itself and rebuild a targeted autoimmune response like lichen sclerosus, how far are we from programming systemic exosomes?
Wow, yeah.
Could we eventually see an IV drip of specialized exosomes designed to rewrite the immune system's baseline entirely? The cure for broader systemic autoimmune diseases like lupus or rheumatoid arthritis might not emerge from a traditional pharmaceutical trial, but from the molecular hacking currently being refined in cosmetic laboratories.
It's a wild thought.
It really is. Well, we want to thank you so much for bringing this fascinating stack of sources to our attention and joining us on this deep dive. Keep questioning the information around you, and we'll catch you next time.